Okay, everyone can see my slides.
Yep, we can see.
So really looking more into like the background. It's a growing worldwide problem in terms of the metastasis. There's disruptions of the blood-brain barrier. There's newly emerging treatments that we will get into, but we'll really like focus on some of the pathophysiology and some understanding of some of the emerging therapeutics that are going through. So you can see that from normal breast cancer, there's the local tumor growth that occurs over time. This can lead to a host of pro-inflammatory pathways, but can also contribute to EGFR and have this local like inflammatory spread. So why is this important? Some of the extravasation that occurs across the blood-brain barrier is due to this increase in VEGF, this EGFR. Typically, these tumor microenvironments are different than the primary environments. A lot of times, the primary environment can be more heterogeneous. Oftentimes, by the point that it's had brain metastasis, it's a single cell line that has deposited. So systemic treatments and focused treatment for the intracranial portion can be variable. We'll go into some of like the mechanisms a little bit further as well in terms of some of the response rates to different medications, as well as some emerging therapeutics. Typically, it's the distal vascular tree, as the audience is well aware of. It's primarily at points where it enters more into like capillary phase. And we're really targeting more of this disrupted blood-brain barrier components. There's infiltration because of those inflammatory markers that can really cause some of the disruption at the tight junctions. That can cause some parasite hypertrophy. There's astrocyte hypertrophy as well. That can all contribute to more of this localized tumor that can grow over time. There can also be specific receptors that are expressed as well. HER2 being one of the most positive. There are as well family proteins. This really shows that targeted therapies, particularly for metastatic lesions, might be a better approach. This is true also for both the progesterone and estrogen receptors being very targeted in that response. Luminal B cancers has much fewer receptors, so these are more challenging in terms of treatment paradigms. We'll go into current treatment paradigms, some potential options that we have in terms of improving some efficacy over time too. As we mentioned, some of the tight junction proteins play a very important process. There's some feedback loop as well. So there's an increase in matrix metalloprotease 9. This can cause some local disruption. There's a recruitment of VEGF as well. That's why oftentimes there can be further metastasis over time as well. It really goes to show that this reactive astrocyte process, as well as some immune infiltration, plays a critical role. It's a very dynamic process once hematogenous spread has occurred. So in terms of treatment, depending on the overall tumor burden, whole brain radiation versus the SRS if it's smaller lesions. Classically, it's been 10 or less, but this is a treatment paradigm has been changing. There's some chemotherapy options really targeting more of the blood-brain barrier disruption. We'll talk about some of the mechanisms by which we can facilitate some improved treatment response. Surgery continues to be a mainstay, especially if there are more peripheral lesions and if they are in an area that risk-benefit favors resection. This can be followed by radiation as well. Here's some of the different types of cancers that the phenotypes and the different medications that have been investigated. So you can see there's some monoclonal antibodies that have been investigated, different responses for triple negative versus HER2 positive. There's tyrosine kinase inhibitors. There's more systemic kinase inhibitors have been shown to be pretty effective. There is combination treatments that are also being investigated, looking at how different targets can facilitate cell death over time, and particularly looking at inhibition of some of the cell cycle, targeting some of the estrogen dependent pathways depending on the type of the breast cancer itself. And then, as I mentioned, some of these combination monoclonal antibodies with more of these systemic treatments. So how do we get these medications there more effectively? And so one of the key limitations is proximity. A lot of times these are more systemic medications. They go through some first pass effect. Emerging evidence has really shown that having more of a focused direct arterial administration from an endovascular standpoint can be therapeutic. It can really increase some of the concentration in vessels that are more close in proximity. This can really target some increased response across some of that leaky blood-brain barrier. This is important in terms of medications that are known to be difficult to cross the blood-brain barrier. There's a lot of preclinical work that has shown that this has been an effective strategy for more local administration, and it's becoming more and more commonplace within the more of the clinical arena as well. In terms of other emerging therapies, there is nanotechnology that is improving. There is some mechanisms in terms of having more of an ultrasound specific response, more of a targeted immune therapy as well. So this has really shown that there can be more extensive penetration of tumor itself, combined with some of the more classic resection and radiation therapies. It's going to improve overall outcomes for these patients. At the same line, there's improving biomarkers. As we'd mentioned, a lot of times the systemic malignancy might be more heterogeneous, where the intracranial malignancy might be more homogeneous. So really having a more targeted response where we're looking at specific serum microRNA changes, looking at more of the JAK2 pathway, specific genetic markers as well, to really pinpoint that the systemic treatment burden might be under control, but we could have a more targeted effect for intracranial malignancy. This shows that this could be a really great advancement in terms of medications that could be targeted to cross the blood-brain barrier and really be more specific to that specific tumor response. We'd mentioned briefly about more of the immune regulation as well, really targeting some of the peripheral immune cells that can cross the blood-brain barrier as well, having a more systemic response similar to approaches that we have seen for gliomas. One of the emerging treatments is focused ultrasound that can cause micro disruptions in the blood-brain barrier that can occur over a short period of time. This can help facilitate medication when combined with intra-arterial injection of some of these more targeted therapies can really enhance the concentration into the tumor bed. That can drastically improve some of the outcomes too. There are several ongoing investigation trials that are trying to facilitate this mechanism as well. There's a thermoablation too from focused ultrasound itself that might be therapeutic, can denature the tumor. So it's a biphasic effect where you're increasing the concentration of the medication, but you're also making the tumor itself more susceptible. So there's a proposed bimodal effect that will occur over time. So, in conclusions, the pathophysiology of metastasis is very complex. There are a lot of emerging treatments that we're using from a clinical side to have important breakthroughs. Ongoing research is needed in terms of the best treatment approach, having a more personalized medical management post-surgical resection. A lot of the trials are advancing from some early preclinical work, but this is a field that will continue to emerge and something that we're really trying to foster with the special edition as well.